Yeah.
All right, so that was a cool case. Here's just a very simple thing that we get asked a lot about the nasopalatine, and it's nothing to worry about. I mean, managing these, I prefer not to have to degranulate within the nasopalatine if I can avoid it. But if your defect is continuous with it, you really don't have a choice. So don't be afraid to do that. This is an exact question here. Patient has a large defect here. This is another example of students that probably came to our course and kind of learned that you don't always have to do everything, in one shot. Sometimes you just want to extract and let it heal. And that's what this doctor did here. But of course, when they went back, look at that defect that you can see in one of the middle pictures on the top of the screen. So a little vertical component there. Again, sticky bone. So they're in Israel's camp here. They used what I believe is sugar cross-linked collagen membrane, but it's interesting. It looks like they used it dry because typically that membrane, when you put it in, you would hydrate it first. I don't think there's anything wrong with using it this way. You just have to be very careful because if you let it hit the blood, it will get very, very sticky and kind of stick on itself. And things are pretty clean. Things are pretty stable. You see they had really good primary closure. And so this is the type of case that, we will all see in the anterior. But when you have, again, the example, this is one of my cases with that very, large defect, that vertical defect on tooth number 9, and it's really almost continuous with the nasopalatine canal. So I really didn't have an option here. And I just you're going to get a little bit more bleeding in these cases. Hit it with 1 in 50 and use really a large degranulation burr, to me is the best way to go. And then you can try to scoop out the rest. Here's just an example, very similar, using that in that same case, just using that dual layer of a collagen membrane. This is why I love this membrane, because I can leave it exposed, not really fighting for primary closure. Don't want to create a mucogingival defect. But you can see here, we did really well, and you get that defect to fill in really well. It's all within the housing of the bone. So don't be afraid of that. But that defect that we showed where you had that vertical component, following the removal of that tooth, that's something in the front of the mouth where we do have a lot of options. And this is something that, Israel started using a new material now. So you can walk through this case here.
Yeah. Before I get there, I'm having trouble responding to somebody in the chat. Somebody was asking, Travis was asking about the palatal screws used an applicator. Yeah. If on the handpiece, there's an adapter. But it looks like I can only reply to Brandy with a DM. So yeah, Travis, there's an adapter for the handpiece for the palatal screws to place them. So yeah, you can see this is another little bridge case. We've got a few of them this evening. You can see that little bridge on the facial. In this case, I was able to keep it like Matt, unlike my first one. And that really holds that buccal plate stability, but you can definitely see the apical concavity. There's no bone there. So I was, playing around with this, one of my first cases, using this Laminar Plate, which is an allograft. It's a de-mineralized allograft that is used as a membrane. And
is there Snoasis, Israel?
Sorry?
Is this a Snoasis?
It's Maxxeus, and
Maxxeus?
Snoasis distributes it. So yes, and you can see over there, that's the bar exclude over the occlusal portion of that. So yeah, you can get both of them through Snoasis. Yeah. But I use the same ribros technique that we do with any other membrane. I just wanted a little bit more stability here and to see what it's like. And but exact same technique. And close it all up. Here you can just see the results of the augmentation. You can see the digital prosthetic design using a surgical guide for implant placement to make sure I'm placing it in the right spot. Make my open it up after 6 months, and hey, remember that defect that there was? It definitely looks pretty nice and smooth. Now, this is one of the things I love about this laminar plate is that the ridge looks like bone. It's not like particulate little pieces here and there. It really looks like nice smooth bone. And so I make one of my customized healing abutments with a surgical guide, place my implant. You can see how much buccal plate there is there, and even take a tiny little connective tissue graft from the palatal aspect. I've been doing that a ton lately. It's inside the flap. It's the same flap. I'm not going to the palate off to the side. like a real root coverage type of connective tissue graft. It's just basically a little scarf on the facial of the.
So when are you taking it? Right before you close?
Yeah.
Okay.
It takes literally 30 seconds.
Nifty.
Mhm.
Nifty little trick.
Yeah, you can see right over there on the palette. I'm pointing at the screen, like you guys can see what I'm pointing at. But I'm right there. You can see how the tissue is a little bit thinner on the palatal aspect, and it's thinner just because that's where I took the connective tissue graft. Patient will never know anything, and you save them some bucks and discomfort, and just put on the facial where it's needed more.